Hi, this is Nicole Kupchik, and I'm here with 10-Minute Tidbits. So today I have the privilege of chatting with Dr. Erik Kulstad, who created a super cool tube that's used to cool patients. And actually, I posted a video on this a couple weeks ago, and there were over, I think, close to 5,000 views of this video. So I've gotten lots of requests for information. So I am lucky to actually interview the inventors. Isn't this
I feel lucky
cool?
to be here. Thanks, Nicole.
Isn't that cool? So just so you guys know, we're in Miami. You can probably see the bay behind us and palm trees, and for us it's like 70 and perfect, isn't it? Okay.
No, it's snowy and cold.
It's snowy and cold, sure, right? So, all right. Well, Dr. Kulstad, thanks for coming here today. And,
thank you for having me.
Yeah, and so what I would love to know, where did you come up with the idea to create an esophageal tube to cool patients? Or warm them. You can actually use it for cooling and warming, right?
Cooling and warming, right.
Okay.
So the original idea came about during the early days of inducing temperature management or hypothermia for cardiac arrest. And in the early days, it was not necessarily a standard. It became a standard over some years in sort of early, mid-2000s. And the technology that we had some limitations. And what I really wanted to do was leverage what I remember doing as a medical student, which was gastric lavage for GI bleeding.
Oh, interesting. So that's how you got the idea.
That's how I got the idea, because it was something that we did almost as a medical student procedure.
Yeah.
It was common in the place that
Was
I
that left for
trained
the
in.
med students?
The med students got to do it on the side of the bed and got to inflate the stomach with ice cold saline. And the side effect of that is that people would get very cold. And so obviously it seemed like a very optimal environment for heat transfer, and thought that that would be a neat way to leverage into a product that would avoid actually having to lavage, because putting in a lot of fluid into a stomach doesn't necessarily help the patient. And being able to connect it to existing water blanket chillers seemed the easier route.
Okay, so you wanted to create a method that could be used with something that already existed out there.
Exactly.
I think that's actually really smart. So you're like, I don't want to, you don't want to start from ground zero and create a whole system. But you're like, what do we already have and what can we add to it?
Exactly.
Okay.
Exactly. Don't want to reinvent the wheel, but want to take an idea that would that had some basis in history and some basis in use, and make it sort of safer, easier, and simpler.
All right. So tell us about this tube. So it's a tube. How big is the tube?
It's almost 12 millimeters in diameter, so it's about a 36 French. So many people won't be old enough to remember the old E-wall tubes that we used to use a fair amount, or the Seng, Steak, and Blakemore tubes that we used to use.
Yeah.
But those of us my age and older remember really large diameter tubes that we used to put in the esophagus for the purposes of either lavaging out big pill fragments or for tamponading bleeding on
like the
esophageal
Minnesota
varices.
tube, or
the Minnesota tube is the other one. Yep. So, and so those are really big. Those are like 3 centimeters in diameter.
So in comparison, this is actually a lot smaller.
Exactly, we're at 1 centimeter. Yeah.
All right. And then where does the tip sits?
In the stomach.
In the
so
stomach.
It just replaces the OG tube that you place in this patient population anyway as a standard of care. So it maintains the functionality of the OG tube, so you can still do gastric suctioning, decompression, you can still give medications, tube feeds through it.
Yeah.
And so one tube that does it all.
Wow. And so I just would love to know the process. Okay, so you've got this idea. Like, how did you get up the courage to say, let's actually make this happen?
I don't know if it was courage as much as naivete and not knowing what was involved, and just asking a lot of questions, getting a lot of good mentorship and good guidance, and taking it one step at a time.
So just I'm going to dig on the process a little bit, because I think this is fascinating. Because I think we need to be innovative in healthcare, else we're going to be in the same stagnant place we always are, right?
I agree.
So so you have this idea. Did you go to someone and say, hey, can you design this for me, or what was that process like?
I didn't necessarily do that first. I went to a group in Chicago that was designed to foster innovative ideas.
Okay.
In particular, sort of first-time entrepreneurs, and so that group it was called Propel. It still is called Propel.
Okay.
And the woman there is Barbara Goodman, who directed it for many, many years. And they sort of gave me my first guidance. They said, hey, here's here's where you have to start. You've got an idea, that's great. A lot of people think the idea is the hard part.
Sure, yeah.
The idea is sort of the first 1% of the work that it takes to get to the point where you have something that you can actually commercialize. So
okay.
that was kind of the start.
Wow. Okay. And then so what was this what was the time span from idea to actually getting something in clinical use?
So the typical rule of thumb for a medical device, especially in resuscitation or critical care, is it can take sort of 7 years plus.
Okay.
From start of the idea to getting into the market. I think we did it in maybe a little under that.
Okay.
6 years.
All right. That's pretty impressive.
Well,
Okay, so what was this FDA application like? I've heard it can be boxes and boxes and boxes of paper.
Although you do still have to print them out. Unfortunately,
Okay,
they're trying to change that, and so
okay. I said that, he didn't, just so the FDA knows.
And FDA is trying to streamline some of the processes, and the European notified body approach is analogous in a sense, but there's a little bit more upfront guidance, so that you can get a little bit more certainty as to what needs to be done to get your clearance. So neither of them are easy.
Okay, yeah, it's a lot of work and dedication, I'm sure. So now you've got this company, Attune Medical, and you are currently the Chief Medical Officer.
Correct.
Okay, and you've got a staff of about 20 people or so?
A little under 20.
A little under 20. And how many facilities, if you had to guess, are using the esophageal device?
Globally, well, so in the U.S., I think we're in maybe 50 hospitals or so.
That's actually
now.
impressive.
So,
okay.
And each hospital has maybe a few different accounts sometimes. So,
okay.
So it's getting increasing interest. It's a slow process getting into a hospital system.
Yeah.
Getting in through the purchasing procedures and so forth. But we're getting a lot of interest, and the clinical data that's coming out is quite impressive. So.
Nice, yeah, and so typically you design this for post-cardiac arrest, but from what I'm hearing, facilities are using it for other reasons, which is pretty promising.
It's been a surprise because my focus as the myopic emergency physician was cardiac arrest as the pain point, and cardiac arrest was what I had to deal with in terms of trying to start cooling, as per the guidance. And what's now turned out to be the case is that the use of the device is sort of across the entire temperature management spectrum. So in the neurointensive care unit, central fevers are really hard to treat.
Oh, absolutely, yeah.
Really hard to
manage and keep it at temperature.
And certainly have an association with detrimental outcome or worse prognosis, worse outcome. And so that is one of the areas that we're used a lot. And then warming. Warming in the OR is really important to prevent all the adverse outcomes that come from inadvertent perioperative hypothermia, things like increased blood transfusions, increased blood loss, increased wound infections, wound dehiscence, myocardial events. All of those are mitigated if you can maintain the patient at normal thermia, but you can't maintain patients that have complex surgeries where they're exposed, wide open, abdominal procedures, spinal procedures, burns, trauma, orthopedic, large joint procedures.
So really anyone who's wanting to manage temperature, or really any patient, you could use this device. Okay, that's really impressive. So, all right, so what are next steps for you? So you're the Chief Medical Officer. What do you want to be when you grow up?
I don't know what I want to be when I grow up. I'm not old enough to know that yet, so I'll keep trying and see what happens. So this is it's really fun to have done all that we've done to get to this point, and have just this great team of folks helping out. And I tell the story now and again to people about asking us why we have done this to date. And one of the first patients that we was treated with our device in Europe was a young patient, mid-40s, cardiac arrest, resuscitated, cooled with the device, made a recovery back to baseline, great CPC, MRS, went home, and a month later came back to the ICU with his daughter, 2 years old, in tow, going to all the staff, thanking them for saving his life.
He
came back, walked in.
Okay. Wow.
And so,
they had a little 2-year-old.
Yeah.
That's, this is why this matters,
Yeah.
right?
Yeah.
To get people back to their previous functioning status. Okay, well, I have to say, I've always been so impressed with you. He's a true innovator, and I love the work you've done, and, I just say keep it up. Now, if people wanted to get in touch with you and find out about esophageal tubes for cooling, how would they do that?
I don't know what the
Website.
easiest way is. Attune Medical, attune-medical.com is the web address. It's probably the easiest way.
And you've got reps all over the country if they wanted to contact. Okay, well, again, thanks so much for being here. We're in Miami. We're sad. We're leaving tomorrow, but we were just at an amazing conference called Chillin' at the Beach and learned lots those last 2 days.
Phenomenal conference.
Wasn't it fun?
Yeah,
it was so much fun. So
this is the 8th annual, the 9th annual next year.
Yeah, so next
Encourage
year,
everybody
you
to
guys come on. March in Miami, right?
It's March in Miami.
Like, how could you beat that? Okay, so this is Nicole Kupchak, and this is Erik Kulstad, and we're here with 10-Minute Tidbits.